Okay, so let's talk about inflammatory disease of the lumbar spine. We've already talked about degenerative disease before. We'll talk about inflammatory disease, and we go on to traumatic and congenital. And I don't think we'll have time for neoplastic, but we'll see. Okay, Dan, what do you think of this case?
55-year-old female with back pain after facet.
You're going to have to kind of yell into the mic over here. Okay?
55-year-old female with back pain after facet injection. Let's look at the left and right T2 images. And then there's post contrast. Okay, so there's a lobulated enhancing. Wait, I don't have a T1, do I? Wait, I'm confused. These are.
Okay.
I'm
So
sorry.
here's the left side.
Yeah.
T1. Here's the right side T1. And here you can see the nerve roots coming in the neuroframina above. If we get to 5, you can see the nerve root with a little bit of fat around it there. But what do you see here?
Yeah, there's like a hypointense signal which enhances.
Right, and you don't really see the nerve root there, right?
No.
And because there's no fat, there's no contrast around it. And here, if we go to the axial images, what do you see?
On the right side, you lose that. It's like infiltrated into that foramen as well.
So here you can see the facet joint on this side. You can see the nice size over here. The subchondral bone is all eroded. And then you can see that there's some soft tissue mass surrounding the right facet joint. So what do you think's happening here?
Possibly some granulation tissue.
Okay, what caused the granulation tissue?
Like maybe some scar tissue from the facet injection.
Well, that's not what I'd be worried about in a case like this. And if you notice, there's a lot of enhancement of the surrounding soft tissues,
and the
destruction of the facet joint. So what do you think this is?
Probably some kind of neoplastic kind of.
Well, I don't know why an injection caused neoplasm.
I know.
What can it cause?
So it's cortisone. So it would just be eroding the bone? And I'm not sure. I'm sorry.
I don't know. Okay, then if you...
it reminds me of pus.
Okay, and there. And then here, if we look on the sagittal images, what are we seeing back here?
So there's, extradural space occupying a lesion.
Okay, so if you just injected a facet joint, what would you be most concerned about?
Oh, maybe you went into the thecal sac? No.
This is an infection.
Oh, it is.
You always have to, the first thing you have to worry about after people violate the skin is it an infection?
Yeah.
This turned out to be a methicillin-resistant Staph aureus infection, starting in the facet joints, and now we can see it's extending out into the epidural space. Okay. All right.
What's interesting is that if you go back, John, and you look at the spine after this, the spine looks, in terms of facets, in terms of discs and so on, look quite normal.
Yeah, just a little desiccation here, a little degenerative.
A little degenerative change, but
I agree with you.
Nothing to brag about. So it makes you wonder, why was the patient injected?
Well, their facet was injected. They thought the patient had back pain due to facet arthropathy, so that's why they injected the facet.
Yeah, well, we know about facets.
Yeah, but unfortunately, this turned out to be a big infection. So that's what a facet joint infection looks like. Robert.
All right. So we have a 46-year-old male with low back pain radiating into both lower extremities.
So this is on 7/13/2011.
Okay. The only thing that stands out is there's a little bit of marrow edema on the L5 vertebral body posterior superiorly.
Yeah. And if I remember correctly, this wasn't appreciated at the time.
Okay.
So this is 7/13/2011. The patient came back later because their symptoms were worsening. Here we can see that. And this is what it looked like 2 months later.
Yeah, so now it looks like it's involving both the L4 and L5 vertebral bodies and the disc space in between. So again, I'd be concerned for osteomyelitis, discitis.
So just remember what typically happens with is this hematologic spread. The bacteria lodge in the small arterioles at the end plate, and it starts with osteomyelitis on one side. Then it goes through the end plate into the disc and then spreads to the opposite side, leaving discitis. And most of the time when it's picked up, it's at the point where the disc is infected, because once it gets into the disc, it tends to spread quite rapidly because it's such soft tissues. So this is staph discitis.
Well, these are extremely painful. What was the guy doing all this time?
I don't know. I don't know any other history, John.
These are very, very painful.
Yeah. Wait a minute.
Okay, so image on the left is a T1. The L4 vertebral body's got uniformly low signal.
And then the one thing to notice here that was classic in the old days when we didn't have a lot to work with is you don't see that end plate on the T1 weighted image, but you do see it on the T2 weighted image. And that's pretty pathognomonic of infection in the spine. We used to use that a lot, especially before we had fat suppressed images where you could see the edema a lot better. So this is in May, and on the T2 weighted image, we maybe see a little bit of increased signal intensity compatible with some edema. That's 5/20. The patient came back now a few months later, and what do you see?
Okay, on the T1 images, we see, similar irregularity in that L4, but now it's involving the L3 vertebral body, that intervertebral disc. And
Yeah. And again, notice how you've just lost the visualization of that subchondral bone of the end plates. And on the T2, you can see that this disc is now involved. It's decreased height of the disc. We can see some edema within that superior end plate. But this again is discitis. This starts at a little later stage than the previous one. We have more osteomyelitis, but it's already affected the end plate. So you know the disc is probably already going to be involved at this stage, though subtly, and then it rapidly progresses once it gets into the disc. And it's just on the axial images showing you can get these psoas abscess or paravertebral abscesses associated with these.
Was he treated between the first and second imaging?
I think so, John, but I don't remember the details. But I'm sure the diagnosis was made here. So I'm pretty sure the patient was treated, but I don't remember the details of the case.
I would hope so.
I would too.
We consider this a semi-emergency.
Right. And then here we can also see discitis, more of a chronic discitis in this particular patient. And this is a previously treated discitis, and you can see just some residual inflammatory disease.
I like the word disc infection.
Yeah, I think that's better too. Because you could have a lot of inflammation, but almost always a discitis means disc infection. But you're right, it could potentially be other things that could cause inflammation.
I think this kind of just means inflammation. So,
Yeah.
but,
Payson, what do you think of this one?
All right, 54-year-old male, low back pain and fever for several days. Okay, we're looking at the L3, 4 disc space there. There's some abnormal signal within the intervertebral disc and some end plate edema. And it looks like there's some extension into that extradural space anteriorly.
Here are the axial images.
All right, so T2 shows bone edema and disc edema, mass effect on that anterior thecal sac there.
Yeah. So here, if we look at these, you could almost be concerned that you've got a big disc extrusion here, right?
Yeah,
Through here. Okay, but here are the post-contrast images.
those contrast. Yeah, so I guess there's a pretty intact looking disc and some phlegmon maybe
Yeah.
there.
And again, there certainly is enhancement here, so it looks inflammatory, but you can get inflammation around a disc herniation as well. So I was
Yeah.
it looks like there's kind of a broad-based circumferential bulge and maybe a focal extrusion here. Would be typically what we would see. Not a whole lot of enhancement in this location. The final diagnosis here is this turned out to be a streptococcus abscess in that area. But I think that almost always most people would call this a disc extrusion. So just
An interesting organism.
yeah, right. And so it's a bit of an unusual organism. The tip off here is that this patient, if I remember right, was sick and actually had a fever. So it was more than just the typical back pain. Hey, Dan.
72-year-old female, chief complaint of back pain, Wong Baker 3.
Yeah, moderate pain.
Okay. Past history of acute renal failure, hypertension, cerebral infarct, anemia, elevated white blood cell, and
Uric acid.
okay, yeah,
Bunch of stuff. Okay,
bunch of stuff.
there we go.
So we have radiographs and a bone scan. Diffuse osteopenia. There is 5432. There is looks like it's a. It looks. I think I can see all the cortices. So it looks like it's a chronic appearing.
So it looks like a compression fracture,
Yes.
right?
Yeah.
And then we see a lot of uptake here on the bone scan.
Yeah.
Here's the MR.
Yeah. T1, T2 facet, and post contrast, which is showing some heterogeneous signal within the inferior end plates of
Yeah.
3 and 4 and 5.
Had a lot of abnormal signal within the vertebral bodies here with some contrast enhancement.
Yeah.
There's the compression fracture we saw before.
There's preservation of the disc spaces.
Yeah, that's interesting that
Yeah.
you actually have bone edema multiple levels, but the disc in between looks normal.
This makes me think about
that's
like
what-
TB caused that kind of scenario, but I'm not sure.
Okay.
Looks like they put some cement
Yeah.
into that space.
I think, yeah, this is the same one. So they put cement in here, so they actually. Okay. So
So
this is what it looked like. Now let's see. This is yeah. So this looks like it's October 12th, 2002, I think. This is November 2nd. No, that's not right. I'm not sure that these dates. Okay, so
They tried to.
I don't know about these dates anyway.
yeah.
So here and then here we can see what the CT scan looked like. This is obviously later. And what do you think's going on here?
So there's been a progression in osseous erosion. It looks like it's going to actually the discs look still pretty well preserved.
Okay, so here's where they injected the vertebral body.
Yeah.
And then now we've got diffuse edema, which is much worse than it was before. We've got erosion of the end plates here.
Yeah.
And now we've got actually have some edema within the discs
Yeah.
and in the anterior soft tissues here.
So discitis, osteomyelitis is
Yeah.
probably still the
And then it progressed on to this. So it's probably somewhat chronic. And so they were concerned about atypical infections, but they grew out no AFB or fungus from the cultures. This just shows how some different things. Disc destruction is much more common with bacterial. The disc is somewhat protected with tuberculosis, as you were referring to, and fungal disease is kind of in between and kind of mass. And then abscesses, big abscesses with TB, small abscesses with fungal disease. And here we can see this again. So again, the dates, this is probably 2010, November 21st, I would think. So this is 2011, February 18th, 2011, March 20th, 2011, September 6th, and we can see the progression of disease, and this turned out to be a fungal disease.
Wow.
Or chronic.
Never heard of it.
Yeah.
I certainly have heard candida. That's common.
Yeah.
Albicans.
Robert.
All right, so we have a 77-year-old woman, mild fever, past medical history of candida and urine and blood, diabetes, hypertension, fracture, pneumonia, elevated white count, RBCs are low, AFB negative, and then sputum showed some candida. Looking at the spine, what is that?
So February and April.
Okay. So there's decreased signal in that lower L spine, but then, yeah, right there, I think is where the action is. A little superior end plate deformity. And then it looks like the signal abnormality has spread to the superior level as well.
Oh, wait, T11 there.
T12,
Okay.
yeah.
All right. So it's spreading. See a little bit of mild uptake on the bone scan. A lot of osteoporosis. Here's February 17th, so kind of in between the other two. And we're starting to see a little bit of disease on T11, but mostly at T12. And this is a month later, we're getting some compression of the vertebral body. Here we're now on April 16th. What are you seeing here?
Here, in the anterior soft tissues, it looks like there's some soft tissue there that looks like it's enhancing.
And
Or it's bright.
much more involvement of 11 now than before. We can see that soft tissue disease with some enhancement there. And this was Candida albicans. Much more, much slower disease than if it were a bacterial, typical bacterial.
The patient is 77, so we're going back to Korea when Korea was eating 1 or 2 bowls of rice a day.
Okay.
Most people were starving. So that goes with the territory. That's why we have so many unusual infections that like tuberculosis is not unusual, but in Korea that's very common. Open lesions.
But this is 2012, John. This wasn't back during the war.
I don't think we see that today.
Okay. All right. Elior.
11-year-old male with 1 month of severe back pain. Right. So in the epidural space, I see this this tissue that enhances. We have contrast enhancement on the right.
Yeah.
Yeah. So the yeah, is that an erosion? Yeah, it looks like an erosion in that
Right.
posterior S1. T2 on the left, T1 on in the middle, and then contrast on the right.
Right.
So enhancing, yeah, soft tissue. So I'd be concerned about an epidural
Right.
abscess and osteomyelitis.
So what this started out as a Brodie's abscess near the end plate that ruptured through the posterior cortex into the epidural space. So that was a ruptured Brodie's abscess. Tayson.
All right, 73-year-old male with slowly progressive back pain. This looks at 2-3. Looking at that disc has a diffusely increased signal there. And on our coronals, looks like we have some extension of that into the psoas muscle.
Right. Yeah, so this turned out to be, I think, a staph infection of the disc with a psoas abscess. Okay, Dan.
Wow. Rough looking spine.
That would need drainage.
Yeah, right, John.
So we have it's T1. And I'm assuming that's another
T1 and a PD
That's
facet.
PD facet. Okay, so it looks like we have a lot of edema within the L4, 5, and S1 vertebrae. Disc spaces are not very well maintained, and there's a lot of signal in them as well.
Okay.
Post contrast, enhancing soft tissue surrounding the vertebra, extending into the left or the right psoas muscle, I believe.
So what's going on?
Thinking that's some kind of
I
infection.
think that's the sacrum is involved too.
Yeah,
Okay.
some kind of infiltrating infection, but not exactly sure what's going on. There's no abscess or any extradural lesion.
So here we can see a lot of degenerative disease, but the real concern is at 4 and 5.
Yeah.
And right, this was a Staph aureus infection.
Mm-hmm.
Okay, Robert.
All right, so we have a 70-year-old male voiding difficulty and back pain. Here there's some signal abnormality at L2 and L3. Yeah, and there's that posterior, looks like a fluid collection peripherally enhancing, so an abscess back there. Yeah, that left. Yeah, so it's an epidural abscess and then a fluid collection in that left psoas muscle, right psoas muscle as well.
Yeah.
Looks like that.
So I think this is another Staph aureus disc infection with psoas abscesses and central stenosis due to the epidural abscess.
Okay, 75-year-old woman, back pain for several months. Okay, on the radiographs, we're looking at L1. Is there compression deformity on that AP view?
Yeah.
Yeah.
So we have a lot of osteoporosis, a lot of degenerative disease, some compression, fractures of indeterminate age really on a plain film. So I bet you want to know more. How did I know?
So on the T1 on the left, the vertebral bodies, the L1 and L2, there's low signal and some indistinctness of the inferior end plate of L2.
there's this disease.
Mm-hmm. Yeah, this epidural lesion looks like an abscess, peripherally enhancing, emanating from that disc. So I'd be, yeah, concerned about infection and
Yeah.
epidural abscess.
There are more than 2 levels involved here. You can get more 2 levels with bacterial type infections, but generally the patients are very sick with just 1 disc and 2 vertebral bodies. So generally, if it's more than 2, you typically think about atypical kinds of things.
Okay.
Because it's maybe more of an indolent, less symptomatic type infection that's more chronic. And then here we can see progression of yeah.
In my practice and over the years, I saw a lot of backs and not that many infections, but it usually just was 1 disc involved.
Yeah, it
So
should be picked up really
here
early.
we're looking at multiple discs.
Here we can see a lot of surrounding soft tissues. And this is Korea. Here we can see more. Here is the CT scan. A lot of degenerative disease, but obviously multi-levels compression fractures, interruption of the end plates, a lot of disc disease, and we can see a little bit of that soft tissue thing. So what would you think about here?
A more atypical infection, if it's more chronic, like TB or fungal disease or fungal
This is
infection.
pretty characteristic of TB. And you can have multi-levels involved, but because in the early stages, it can be relatively asymptomatic as opposed to staph and strep, which is usually very symptomatic in the early stages of infection. Okay, Taysom.
All right. 58-year-old female back pain for several months. Is this a contrast study? Or am I looking at
I don't think so. I think it's just a CT.
just a lot of destruction of these vertebral bodies on axial?
Right. Maybe some perivertebral soft tissue mass.
Large erosion there in the vertebral body.
We're probably going into a different level there. We go to there's the MR scan.
Okay, so it looks like lower thoracic spine, and then we have a skip down to the L3 and L4 vertebral bodies. Have some increased signal in there too.
Mhm.
Yeah, it looks like there's some sort of epidural soft tissue that looks like it has mass effect on that spinal cord.
Yeah, now if we get to the tumor section, what I'll say is if you see bowing of the posterior cortex like this, that's highly suspicious for malignancy. Unless it's both sides and you have extension like this, what this represents is a lot of chronic destruction of the trabecular bone, which weakens the vertebral body, allows bowing out and bowing of the cortex, and then later the cortex may fracture. So it's very typical of destruction of the trabecular bone from kind of chronic malignancy or with malignancy. But there are some chronic slower infections that can do that as well, which is the case here. And we can see there's severe central stenosis. But here we've got, as you said, skip lesions. And what is skip lesions in the spine make me think about in terms of infection?
I don't think
I
that's,
would like to get a chest X-ray in this patient.
yeah, I would think TB, right?
Yeah,
Yep.
this is very characteristic.
Well, it's Korea.
Both of you passed. Dan.
61-year-old female, lower back pain, T1 axial, and that's PD, I think, also.
Okay,
We have some posterior element isotope signal on PD on the also on the Oh, wait, no, a little bit hypertense on the PD. On the T1, it's hypo.
It's okay. So this is T2.
That's
This is
T2.
a stir. I think these are T1 axials.
Okay.
This one, this is different. This may be a T2 and a T1. Okay. So what do you see here?
So within the left facet at L4, L3.
Yeah, we need other images to see whether this is S1 or,
Yeah.
but there's some sort of a congenital variation at the lumbosacral junction that we had value. We don't really have all the images to do that, but fine. So for the purpose of this discussion, let's assume this is L5, or
Okay.
maybe S1, and that this is L4.
Okay, so L4 facet. Yeah, there's an increased signal
Okay.
on the stir. Post-contrast enhancement show.
It looks like pus.
Yeah. Yes,
Ah.
post-contrast enhancement shows peripheral enhancement of around that facet joint with destruction of the bony destruction. I'd be concerned about like an abscess around the
Yeah,
facet joint.
so this really looks like infection to me. It could be a number of things. Clinically might help depending on how sick the patient was. The patient wasn't all that sick, and this was also a TB infection.
Wow.
Okay.
All right, so we have a 66-year-old woman, CRF, chronic renal failure, diabetes, back pain. This is in June of
Typical
20.
patient.
Yeah. Here, I don't think I see a whole lot. Yeah, now it looks like there's been some.
Okay, so this is June 24.
Uh-huh.
We don't know the year. Now we're in August 14th, a couple of months later.
Here, I think it's L2. There's a lot of superior end plate irregularity and really looks almost erosive.
It's a compression fracture.
3.
I think that's 3.
Yeah.
Okay. All right. So what would you be concerned about on the brain front?
So either a compression fracture or infection.
Okay. Yeah, the margins are
Well, you
pretty
can have both. It's
Yeah.
at first you say it's a compression fracture, the fact that it's deformed, and
Right. But
whether it's infected, you have to have an MRI.
yeah. And I think the other end plates, the adjacent end plates aren't entirely normal.
Mm-hmm.
That's what a normal end plate should look like. And
Mhm.
we're really losing the end plates there. So the MR scan, here's your MR that John wanted.
So yeah, there's loss of the normal signal on that top row. Pretty much, yeah, there's a end plate deformity at L3.
So we're at 2 discs, 3 vertebral bodies.
Mm-hmm.
And here are the axial images, a lot of surrounding soft
Yeah.
tissue. Yeah, so here's the CT scan.
Yeah, there's a lot of soft tissue, peripherally enhancing. Looks like abscess.
Now, if you see big abscesses in someone who's not all that symptomatic, they're often called cold abscesses. What does that make you think about?
I don't know.
That's very characteristic of TB.
Okay.
You can get massive, but in this case, the TB was negative. But if you see large abscesses in someone who's not all that sick, especially in the spine area with kind of spotty disease, that's usually going to be TB, chronic TB. In this case, it was aspergillosis, which is much less common.
Would a clue in that also be because it looks like they had a renal transplant, so they're possibly on some kind of,
Yes, and that's why they're at risk for aspergillosis. Good. Here, I'll take this one. So here at T2, we see the end plates, but edema within the disc. On the T1, the end plates are gone with loss of the fat signal on either side. So this is pretty characteristic of disc infection or discitis, like we talked about before. And this is someone who developed an infection of the disc after surgery. Okay, patient had epidural anesthesia.
Okay, so 45-year-old woman.
I used to see this a lot, and I haven't seen it, well, I haven't done a lot of spine in the last year or two, but for the last 20 years, I haven't seen very much of this.
Yeah, so it looks like the cauda equina is being pushed anteriorly.
Okay,
So there must be some, and it looks like fluid behind it. So it looks like maybe some fluid was injected in the,
yeah, and we don't really see
Fecal sac.
separate nerve roots here,
Mhm.
which is classic for this, for what we're talking about here. And here on the axial images, what do you see?
Right, the nerve roots are not in their normal formation.
So we used to call this clumping of the nerve roots.
Right, okay.
Does anybody know what does that mean?
Arachnoiditis.
Okay, good. So, and this was thought to be secondary to the injection. And this is
And they call it clumping.
clumping, right? Or arachnoid adhesions is another commonly used term for this, which is arachnoiditis. Okay, that's just another example where you don't see the individual roots. That it looks like they're all clumped together, and this very disorganized appearance on the sagittal images. On the axial images, you can see that the roots are all clumped off to one side, and together, all clumped in here in the middle, typical of arachnoiditis. But again, this was something when I was a resident that we saw fairly frequently. And here we can see it almost looks like the cord going down further, but this is just clumping of the
No,
nerve
you would
roots.
see it's almost like Korea.
It almost looks like a spinal fluid there, but this was there. That we finally get down to the separate nerve roots, and again, arachnoid adhesions. Okay, Tayson, right? Tayson.
All right, 57-year-old male, low back pain and lower extremity numbness, status post disc injection in 1973. What year is it now?
Now, let me just say, this would be 1988,
Okay. Um,
recent case.
so, he's multi-level disc degeneration, most pronounced at L4 or 5 there.
All
A
right.
lot of remodeling of the articular surfaces. See this kind of low signal within the spinal canal there.
Yeah, what's all that stuff? It's a little central stenosis there.
Yeah.
Okay. Notice kind of the edge along here. Here are the axial images.
Okay. Are those clumped nerve roots as well?
Yeah, so we've got a bunch of clump nerve roots here as well. And this was actually ossified if you did a CT scan. So this is arachnoiditis or arachnoid adhesions. It's chronic for many years, and you can get ossification in it, in that area. Okay. And here again, we can see a lot of soft tissue thickening. This is in the facet joint, marked irregularity and destruction of the facet joint. Here we can again see degenerative disease on the right side. Looks like destruction on the left side with inflammatory tissue going into the neural canal as well as peripherally. This was another infected joint. Okay, Dan, what do you think of this case?
T1 on the left, T2 on the right. Looks like there's hypointense signal on both the T1 and T2 images of the L2 vertebra, the anterior superior aspect.
Let's go look at this.
Yeah. Disc spaces and plates look
Okay,
pretty normal throughout look similar at each level, so I don't think there's any extension into the disc at all.
Okay, so this is February 15th. This is now 2 weeks later.
increased uptake at that vertebrae.
Okay. And then now, 6 weeks after the first
Oof.
one, it looks like this.
Yes. So there's extension into the superior, into the disc,
Yeah.
and also the
So the,
L2
and then on the T1, we lose the end plates again. So
Yeah.
a typical classic infection.
Mhm.
And this,
I have
okay.
I have a question.
Yes.
Maybe Tayson can answer it. How long does it take for an X-ray to show up with an infected disc?
Dan?
I would think it would take. I don't know the answer to that. I'm sorry.
7 to 10 days.
Oh, wow. That's fast.
Okay. So,
So you want to treat somebody like that a lot earlier.
yeah, right. You don't want to wait 2 weeks to treat the patient.
Yeah.
Right. And so here we can see, obviously, osteomyelitis extending into the disc, going to the opposite side. The patient was put on antibiotics, and here we can see after about 6 weeks of being on antibiotics, you're starting to see that you can see the the end plates come back again with healing of that. Though there are erosive changes that are chronic, and you'll end up with marked chronic narrowing of the disc space. So that's what happens when you treat an infected disc. Okay, Robert.
All right, so we have a 68-year-old male, back pain, recent trauma history. Yeah, it's like posterior epidural space, kind of, yeah, right there. There's a fluid collection, kind of heterogeneous, some peripherally enhancing. Yeah, up there as well. There's an additional one anteriorly. Yeah, looks like it extends pretty much throughout a large portion of the T-spine. Right paravertebral soft tissues, peripherally enhancing, central low signal.
Looks like an abscess.
Yeah.
That looks like an abscess.
Yeah.
Mm-hmm.
Yeah, and I don't know the organism on this one. He just called it a pyogenic spondylitis. First thing I would think about in a situation like this would be TB, but if he used the term pyogenic, I think Dr. Sue, this was probably,
Now, these folks are sick.
yeah, right.
Okay, 26-year-old with severe pain at the top of my ass crack. Outside red X. What? Okay. T1.
That's a literal explanation.
Yeah. So we have T1 and is it with contrast on the right, maybe?
Well, I think these are two adjacent cuts,
Okay.
and then I think this is what he's talking about. It's the stir sequence. So here's T1,
Uh-huh.
and there's stir.
So
Actually, this is probably T2, and this is stir.
okay. Yeah, some increased signal there like in the superficial soft tissues. It looks like fluid.
What would you do about it?
I mean, you see that a lot. I don't know. I don't know if I'd be that worried about it.
Okay. Well, they stuck a needle in it and they drew down 50 cc's of pus. I think this was a strep infection.
Wow.
So,
Usually you have to open those up wide and leave them open until they look decent, and you might close them up. You get hair in there and so on.
okay. All right, Tayson, normal or abnormal?
Definitely abnormal. So in our T1 images, looks like a lot of indistinctness of those end plates in the disc.
So you've lost the end plates again.
Yeah, and on the T2 image, looks like a lot of increased signal within the disc and destruction of the end plates.
Yeah. And so this was also a bacterial discitis. Okay, Dan.
73-year-old female.
It makes me wonder who treated these patients.
Yeah.
73-year-old female, low back pain for 1 month, diabetes mellitus for 20 years, 4 years gangrene 3 months ago. Oof. So there's CT, axial and coronal and sagittal showing multi-level end plate destruction and disc destruction as well. Looks like there's some extension of soft tissue anteriorly, spanning from maybe like L3 to
Yeah, and extending out into the
Yeah.
psoas muscles.
Yeah.
Here's the MR.
T1, T2, and T2 post-con, or T1 post-con.
Multi-level disease.
Yeah, exactly, multi-level. Ooh, so it looks like they did aspirated it.
Yeah. So what do you think this might be?
Multi-level like that. It's hit the disc spaces. So I was thinking possibly TB, but I wasn't sure about
Yeah,
it.
I'd be concerned about TB.
Yeah.
They were too. They were concerned about fungal. Pyogenic, there's a lot of disease there that'd be much sicker, and this turned out to be Candida.
Hmm.
And another fungal disease. The more discombobulated things get, the more likely it's going to be fungal because it's more chronic. Yeah, these just correlate with symptoms and findings. But the bottom line is you have to get cultures on these. Okay. Okay. Robert.
All right, so we have a 26-year-old professional hockey player with back pain. Looks like there's that disc extrusion at L4-5 posteriorly, a disc protrusion at L5S1. Yeah, looks like again a disc extrusion. Yeah, right there. A little bit of.
Okay, so it's 11/29/09.
Mhm.
This is 12/14/09.
And it looks like there's some extruded disc material, the
Yeah, so
sequestration.
right, this big sequestered disc at that 4-5 level. So you can see there, here is a sequestered disc on the axial images. He wanted to get back into playing as rapidly as possible, so they operated on him. And 5 days after surgery, he spiked a temperature and it increased back pain. And this is what it looked like.
So there's a lot of, I guess, edema along the surgical tract there.
So you see the surgical tract edema.
It's incisional infection.
Well, that's what we were concerned about. And you can see that there's
Thing about this case is it'd get better off without surgery.
complex fluid. Yeah, that's situation in this is that if he's not a professional athlete, sequesters discs like that all resorb, and usually they're asymptomatic within 9 months. But by doing surgery, they can immediately relieve the pain, and often they get back to playing earlier. But then you've got risks like this, and there's complex fluid in the area where the disc was. Not a lot of edema along the tract. So it was thought that this was a post-op hematoma at this particular time on 12/23/09, but he got worse over the next week. And here's what it looked like on 12/28/09.
Yeah, now it looks more like an organized fluid collection, some peripheral enhancement. So I think that's some phlegmon and developing abscess.
Okay.
Yeah, that looks like an abscess.
Yeah.
Hematomas improve with time unless they're infected. So if you have a hematoma that's got infected, that's pus.
Okay, so they
Different.
did put him on a 4-week course of IV antibiotics, followed by 2 weeks of oral antibiotics. And then they followed him, and he started having increased pain. And finally, in March, he came back for another study.
Did he finally have it drained?
Not at this point.
Yeah, now it looks like there's complete disc height loss and erosive changes of the end plates. So I'd be concerned about discitis, osteomyelitis.
That disc is gone. Forget that disc.
Yeah. And there's where the surgery was. Yeah.
Probably would get fused.
Yeah. So that was just incompletely treated. So it really needed to be drained and much more antibiotics. And obviously it ended his career.
That's too bad. Wow.
Yeah. Okay, let's see.
PICC line for what is it now, John? PICC line for 4 to 6 weeks.
I'm sorry, say that again, John.
Now they use a PICC line for 4 to
Right.
6 weeks. You don't
Yeah.
stay in the hospital.
Yeah, 4 to 6 weeks. But if you have an abscess, it almost always needs to be drained.
Well, the abscess you have to drain.
And I don't think they did that here. They just tried to treat with antibiotics alone. Eleor.
Abscesses do not respond to antibiotics.
Yeah.
Yeah, so here we have a 76-year-old male, low back pain and sciatica for 5 weeks, rule out herniated disc. Yeah, looking at that sacrum on the T1, just low signal, don't really see the bone well. On the T2, yeah, there's just
Notice again, you lose the end plates on the
Yes.
T1. It's
Yes.
really an interesting sign. And they're nice and visible on the T2.
Yeah.
Okay. Soft tissue stuff here.
Mhm. Yeah, and the axial T1 just loss of that normal bone signal with extension. And the CT, not sure. Just I mean, the bone looks a little loosened, and
A little bit.
maybe on the ilium as well.
Here's the coronal
Uh,
MRIs. Maybe a little irregularity up here, but it really looks like the infection is in the sacrum.
mhm. And in the right greater trochanter region as well. So infection in multiple
12.
areas maybe.
And there's PD facet. There's the T1 post where you can see multiple areas that aren't enhancing with contrast that kind of have REM enhancement. So they did a biopsy here. Here's the PET. CT post drainage. And this turned out to be Staph aureus osteomyelitis.
Okay.
So why don't we stop there and we'll pick up. We will not have lecture tomorrow, but we'll pick up on Monday. Okay?
Thank you.
Thank you.
Monday?
Monday.
Well, have a good Friday and
Thank you.
a good weekend, everybody.
You too.
Thank you.